Nitin Sinha.
Can we have the first slide, please? Okay, thank you, and thank you, Dr. Paras, and the members of the organizing committee for inviting me for this talk and panel discussion. I am supposed to introduce and talk about the pharmacological treatment of overweight and obesity. I'm just looking at the time, the clock, because the time has been changing from 20 to 8 to 10, and the program shows 15, so it's 10. So I prepared my talk for 15, but I'll make it 10. So I was waiting for the clock to start. Okay, so what I'm going to do is, basically when we talk of pharmacological treatment of overweight and obesity, there has been over the years, last 20, 30 years, so many drugs have come and gone in the development of anti-obesity pharmacotherapy. Future is bright. And when we make both these statements, what do we have at present? Practically nothing in terms of pharmacotherapy. The only drug we have, and we can talk, is Orlistat in our country, and a few more which are in the horizon. So basically, to sum up, we have only one drug in India to be used, which has its limitations, but the future is bright, as you will see. Why people living with obesity need pharmacotherapy? We've heard about lifestyle in the last talk, and there's a lot about lifestyle which we have to do and achieve, and that's the cornerstone obviously for treating obesity. But not all patients can be treated and controlled only on lifestyle, and therefore there is some role of pharmacotherapy that adds, because the need for drugs comes because if you don't reduce weight, as Dr. Chawla has already initially told, you'll end up with a whole lot of comorbidities and you don't want them. Therefore, there is a role of pharmacotherapy. You must try and do everything to bring the weight under control. If lifestyle doesn't do it, then you have to fall back on pharmacotherapy. Now, I'm very thankful to Cheryl for having, extensively quoted these guidelines. These were prepared by the Endocrine Society of India, led by me and our core team, and it was published only a week back in the Endocrine Society of India journal. And I encourage all of you, because it's there on the journal for those who want to extensively practice obesity or who are endocrinologists, but even for physicians, there is a smaller, more abridged version which is going to come up on the website of ESI very shortly. And there's also an executive summary which is going to come out, which will be easy, user-friendly for everyone. So I encourage all of you, because we all talk about what do we do in India. And these are perhaps the most comprehensive obesity guidelines as applicable to India with all its nuances. And there's an editorial also written on that by me as the editor of the journal. And that also I encourage you to see, because it just very briefly focuses on the challenges of managing obesity in our country, the need and the challenges. And it's not just, reduce this weight and that, and at the end of it, there are a lot of things which you need to consider. And also, we have called upon there, just like as we, public health, there is a call about an NFLD, cause about diabetes and so on. I think the fundamental thing actually is obesity. So we need to sit back and say that a call of action is required for managing obesity, but that's the root of everything in all patients, on all individuals practically. So with that background, again quoting from the same guidelines, a few slides. Few of them would be repeated, but I won't stress on them because Cheryl has shown them. These are the goals. See, when we talk about obesity, there are certain goals we need to define, and the goals are basically to keep the patient metabolically healthy, manage his comorbidities, and of course, apart from that, various psychosocial issues. And weight loss should not be the only goal. Weight loss is part of the entire management. And therefore, a lot of things have to be done, which we will talk about. This is what is important. We should set realistic goals. Cheryl did mention that you don't have to look for ideal body weight all the time. What is important right at the start is for us to understand, first step is to prevent further weight gain. At least stop the weight gain. That must be the most immediate goal. The next goal can follow, where it's a short-term goal, where you want to reduce body weight, and the short-term goal can be 5 to 10%. And as Dr. Chawla and probably Cheryl also showed, even 5 to 10% of weight loss can achieve wonders in terms of a lot of change in several comorbid conditions, especially if it is done through lifestyle. And then of course, if the interim goal is, again, was mentioned by the previous speaker, Having achieved some weight loss, the next target would be to maintain that reduced weight, which is a tough thing to do. And finally, if you've been able to maintain the initial 5-10% of weight loss, then think about a long-term additional weight loss and think about maintaining the achieved lower body weight over a long term, over years. So it has to be phased out. You can't straight away talk of ideal body weight. It's not practicable, feasible at all. This has been shown. I will not talk. This I'm only going to show to talk about pharmacotherapy. This slide has been shown. See, as you can see very clearly here, in those without comorbidities, anybody above 27 BMI in our country should have pharmacotherapy, whatever exists. And if they have comorbidities, even one of the comorbidities like diabetes, hypertension, dyslipidemia, sleep apnea, and so on, you might start pharmacotherapy even at 25. That's all I want to say from this slide. And these guidelines say the same thing, and I have already marked out in red the pharmacotherapies, the comorbidities that you're looking for. Monitor for weight loss and adverse events in at least monthly in the initial 3 months. 3 months is important because what happens in the first 3 months probably tells you what will happen in the long run. Effective response of pharmacotherapy is defined as a weight loss of less than 5% body weight in 3 months. So if you can achieve that, continue the pharmacotherapy. If you can't, change over to some other drug. With pharmacotherapy, that is. So with that background, and quickly moving on to what are the drugs that are available, I don't have to touch too much of these. At present, these are the drugs which are actually available across the world or are emerging. What we have and approved for use in India is only Orlistat, for obesity, that is. We know it's a lipase inhibitor. It can achieve modest weight loss of 4 to 8.8 kilograms. That is a percentage of weight loss from baseline to a year. If it's liraglutide, which is not yet approved for obesity, it can be little more, 7.4% as compared to placebo. Semaglutide, which is coming up again, is supposed to be better. You can achieve about 16.9% weight change in a year. And the combinations again, which are available across the globe but not yet approved in our country, not available easily also. A combination of naltrexone and bupropion, again 5 to 8% weight loss is achievable. And phentermine and topiramate, again, especially in different combinations. If you use 15 milligrams and 92 milligram combination, you can achieve a fairly good 10% weight loss. So pharmacotherapy does have a role. We don't have many options available for us here. There is something emerging in the form of semaglutide, which I'll touch upon. The problem is with Orlistat, it's a thrice daily dose, oral drug, but liraglutide is a daily injection. Semaglutide is a weekly injection. Oral is coming up, but then it has to be evaluated. And it has several side effects which will not go into. There are side effects of each. Orlistat, which is available, you have a lot of flatulence, oily discharge, and so on. And also sometimes have fecal incontinence, malabsorption-like syndrome, and so on. So those are the problems in Indians particularly. Only modest weight loss, but that's all we have. The other side effects I'm not touching, except that the liraglutide, semaglutide has the same side effects. You need to use it in obesity at a higher dose, so side effects are likely to be more, but they seem to settle off, and over a period of time, they probably pass away, as some studies have shown. The approval status I've showed you, the only approvable drug at the moment in the bottom is Orlistat. The others are all not yet approved in our country for obesity. Of course, in diabetes, it's a different story. They're approved for diabetes, therefore it can also have a concomitant weight loss as a target. 1 or 2 slides about semaglutide. It's supposed to be very, very good. The percentage of weight loss, as you can see here, more than 5% in 86% of patients is seen, and it's been seen that even it can achieve as much as 20% or more, and 15% in 1/4 of patients. So it's a good drug, very effective drug, supposed to be in terms of weight loss achievement, even at week 68. So it's a sustained weight loss. So semaglutide seems to be promising and might come up in the future. The important thing, this slide, what are the limitations of pharmacotherapy? The next 2 slides will focus only on the limits. Weight loss is one part. The problem is that despite the weight loss, they don't have very significant effects on the cardiometabolic risk or risk factors. So what is the use of that weight loss? What you can achieve through lifestyle, these pharmacotherapies don't actually provide that cardiometabolic risk benefit, although you have weight loss. For example, you can see here, although the benefits are there and there is decrease in waist circumference, some moderate decrease in HDL and so on, but on the right side you can see that several other parameters are not even touched upon, and therefore that's a major limitation. Before semaglutide, as we'll show in the next slide, no drug improves all the cardiometabolic risk factors, which is our primary goal of treating obesity. That's another limitation. It's only this semaglutide, which has been shown in recent studies, has additional benefits, not only in glucose metabolism, but also on cardiovascular risk factors, and therefore probably it seems to be promising and achieves the twin objective of weight loss as well as cardiometabolic risk reduction. Orlistat is the only drug available. 120 milligram thrice a day is the dose to be used, and it can be used for management of comorbidities. The important thing in pharmacotherapy, I'll just take a minute or so, if the chairs permit me. We talk about anti-obesity pharmacotherapy. What we forget is the pharmacotherapy that we use for treating various other comorbid conditions. Many of the drugs which we use for those conditions have a propensity for weight gain. So while we are trying to tackle obesity by lifestyle or by pharmacotherapy directed towards the weight, we are at the same time using other agents which tend to gain weight. And therefore we need to be careful and look at those drugs. Some of the groups are given here, and this is the list which is provided by the Endocrine Society. If you treat diabetes, choose the right column drugs, not the column in between. Hypertension, don't choose beta blockers, choose the ACI inhibitors, ARBs and so on. Antidepressants, you all know, can cause weight gain, several of them, and therefore be very careful in choosing the right antidepressant. Drugs used for neuropathy and anti-epileptic drugs, very common to use gabapentin, pregabalin in diabetics, obesity, and all of them has weight gain. We don't even think about it. And so be careful when you choose the drugs that you use for all these conditions. With that, just a couple of slides on future, because I don't have to stress. There is a drug, tirzepatide, which is both a GLP-1 and a GIP-1 agonist, which is showing a lot of promise. Significant weight loss in the dose of, in the higher doses, it causes almost 20% weight loss at 72 weeks, so might be useful in the future. This is a combination of an amylin analog and semaglutide, again supposed to be very useful, combining two mechanisms coming up. And this table, as I said before, number of drugs lined up for the future. So future is bright. Thank you.